Good afternoon and welcome back to Aortic 2021. I hope you're enjoying the conference thus far. I hope you're enjoying all the thought-provoking presentations, and I hope that you're able to explore the virtual network successfully. So, with no further ado, let me introduce the next session. The next session will be dealing with urological malignancies, from the screening and prevention, through genetic aspects, through the treatment, and right through to updates in imaging, diagnosis, etc. So just about everything and anything about prostate cancer. Our facilitators are Mohammed Jalal and James Mensah. Over to you.
Thank you. I would like to take this opportunity to thank Aortic and the organizing committee for giving us the opportunity to discuss this urologic malignancies. So, and to also to ensure that we have speakers from different horizon, which will give us different perspective. So we have we are going to have the presentation first, and then we'll have a discussion session. Without further ado, we'll hand it over to Dr. Rebek, who will talk about how to achieve early detection on prostate cancer in Africa. Thank you.
Thank you, Dr. Jallo, and to Aortic. I would like to spend the next few minutes talking about how we can achieve early detection of prostate cancer in Africa. Give you a few thoughts about the background to this topic, and then I'll provide some discussion points that hopefully we can have some questions about at the end of the session. So as you're all aware, mortality from prostate cancer in sub-Saharan Africa is the highest in the world. Is shown on this slide. The estimated age standardized prostate cancer mortality rates are darker in the countries with the higher rates, and you can see men in sub-Saharan Africa die at the highest rates of any place on earth, with similar rates in the Caribbean and some other parts of the world. So this is a major public health problem for the African continent, and it's well understood that due to demographic changes, older age distributions, etc., this mortality rate is likely to increase over time and get worse. In the next 20 years, it may more than double. So we have a public health problem. We know from previous work that PSA in men of African descent, or prostate-specific antigen, the major screening tool that's used to detect prostate cancer, is very high in places like Africa and the Caribbean, particularly where there is no widespread screening, so that these are all PSA levels in men who are diagnosed with prostate cancer. So you can see that in Africa, the median PSA nanograms per milliliter is around 60 in Dakar, 52 in Accra, etc. Places where there's no widespread screening for men of African descent, so that the PSA levels are really quite high. And if you look at the United States, where widespread screening is available, there is much lower levels of PSA at time of diagnosis. So what this reflects, at least in part, is that the severity of disease and the advanced nature of the disease is much greater where there is no widespread screening. So this suggests that using PSA or using screening has value, at least in terms of being able to identify lesions at an earlier stage. Unfortunately, the data that we have so far of PSA with or without DRE screening from the major trials, and I'm just presenting two here, the PLCO trial and the European trial, which involve very large numbers of men in middle ages, 50 to 74, had follow-up for 13 or 14 years, showed very small benefit. Number of lives saved in the PLCO trial was essentially none, and in Europe, 1.3 per 1,000 men screened. So this is a little bit disappointing because it told us that while PSA has thought to have some value in the ability to detect cancer early, the results of these trials suggested that they did not save a lot of lives. And it's very difficult because we know that there are, as I'll talk about in a minute, toxicities associated with this screening. And the major problem that we face, in addition to these limited data, are that there are probably not going to be any trials in Africa. There's not going to be a PLCO or an ESRPC trial in Africa anytime soon for logistical reasons, but also given the findings in the United States and Europe, it's very unlikely anybody's going to be interested in doing a trial, even if the money were there to do it. So what we've learned is that PSA has potential harms and saves a relatively limited number of lives. So this is a figure from the US Preventive Services Task Force that described the use of PSA and its value. So this is telling us that out of 1,000 men screened, about 100 to 120 get false positive results that may cause anxiety, lead to biopsies, and overtreatment. Biopsies certainly can have their own negative side effects, but they're relatively minor. Of those 1,000 men that are screened, 110 will get a diagnosis of prostate cancer. And at least 50 of these will have treatment complications such as infection, sexual dysfunction, bladder or bowel control problems, etc. 4 or 5 of these men will die from prostate cancer, while we know that 5 will die among men who did not get screened. So what we've learned from these data from the trials is that we will really avoid 0 or 1 deaths from prostate cancer. And at the same time, we'll have 50 men have treatment complications. So this is a real problem. This is telling us that we're really causing more harm than good by using PSA as a screening tool. Keep in mind that we're talking about screening as opposed to management of prostate cancer or diagnosis. So PSA still has a role in diagnosis of cancer in men who are suspected of having cancer, but screening seems to have limited value. Now, this is a little controversial again because the data from the European trial suggested that the benefit was a little greater, but still people are very concerned about causing more harm than benefit or saving lives, and so it's not clear what to do. There are current recommendations that have been made from a number of different groups, and of course I won't be able to go through this table in a lot of detail, but a number of organizations around the world have suggested that PSA could be used at certain ages and using PSA with or without DRE, that one should stop screening when you have less than 10-year life expectancy or around age 70 in general. All of the recommendations that suggest PSA should be used suggest that a doctor's discussion should be given so that a shared decision-making with the patient should be undertaken. And the frequency varies, but essentially suggested every 2 years, but it might occur more frequently if PSAs were elevated at any point. And they do recognize that some risk factors like being of African descent, having a family history, or having a BRCA 1 or 2 mutation might influence these decisions. So right now we have data that are essentially at this level. We have some recommendations that are cautious and require really individualized decisions, not a lot of very strong data for the benefit of PSA in resulting in lives saved. So we have very limited data in Africa. We have some data that suggests the distribution of PSA, as I've shown you in the previous slide, but we really don't have a lot to build a PSA screening protocol in Africa. So here are things I think we need to consider. That prostate cancer specific mortality is high and increasing. And the evidence base is really very limited. There's no clinical trial of screening likely to happen, and not all African men should be screened, just as you've seen with European or US men, that there may be harms. And so it's going to be important to identify risk stratified approaches to minimize harm and maximize benefit by thinking about the potential to use family history, age, or possibly obesity as factors that may decide who should be screened, and possibly genetics, BRCA1 and 2, HOXP13, or polygenic risk scores that might suggest increased risk of prostate cancer. So, but these need to be implemented, models need to be made, which they don't exist for African men. It's also an opportunity because we can think about leapfrogging new technologies or approaches. That is, it may not be that PSA is the right test. We have very limited information about whether PSA is a good diagnostic test in terms of sensitivity, specificity, or positive predictive value, although there are some data, but we might want to think about the new technologies and clinical capacity. How the centers in Africa can achieve the investment that is required, the cost of testing, and the management, including the ability to identify and then treat or manage men who have a positive or an elevated PSA or other test. And this is going to involve not only awareness and information from policymakers, clinicians, and the general population about its use. So this is something these are things that we need to think about. But again, given that we're not going to have a screening trial, what do we do? How do we think about PSA testing or other screening in Africa? So here's a thought about how one could move forward with this. One way is to begin by developing expert recommendations and panel a multidisciplinary expert group that might include the colleges of surgeons or other groups, non-governmental organizations who are interested in these activities, the World Health Organization, perhaps bodies like ECOWAS or the African Union or the East African Commission, who would be involved in funding or overseeing these kinds of activities, including government, other governments, national governments, clinicians, laboratory staff, policymakers, community members, and other payers, insurers, private or public. It would be important to assess the goals for prostate cancer screening. Why is it that this would be done? Why might it have value? What are the harms? We can begin by starting a systematic literature review and a summary, which has been proposed, adapt data-driven best practices from other regions, and assess the utility of implementation in African clinical practices. So developing expert recommendations is something that has been proposed by the MADCAP network, and Dr. Jallow, who is the chair of this meeting, has been involved in starting some of these activities with the larger MADCAP group. We'd like to be able to evaluate, once we have some recommendations in process, evaluate patient and provider knowledge, needs, preferences, and practices to understand why this can be done and how it can be done, perhaps through qualitative assessments, and pilot implement these guidelines in some African centers to see whether they work, how they work, and whether they actually result in benefit. So this is a step that I think we should begin to take, ask ourselves whether evidence-based recommendations can be made and implemented in Africa, particularly in the absence of a large randomized clinical trial. If this step can be taken, then it may help us to understand whether it's worthwhile to consider population-based screening in Africa and under what circumstances. So let's start a discussion on this topic. I'd be glad to take questions and have that discussion in the session following. Thank you.
Thank you so much, Dr. Beck. I think we're going to move to the next presentation. I heard that Pedro is not going to join. Do we have Mr. Jagul? I think the next presenter that we have here is Sitna M1Z, who will be presenting on systematic therapy for prostate cancer. Dr. Sitna, please, you have the floor.
Thank you, Dr. Mohammed, and thank you for the invitation to present on systemic therapy. As many of you know, this is not an easy topic to present in 10 minutes, so I'll try my best to go as quickly as possible.
I think you can have more than 10 minutes.
Okay, thank you. As has already been highlighted by Dr. Rebek, prostate cancer is a big problem in Africa. An estimated 90,000 new cases estimated to be diagnosed in 2020. And I think you've already seen the mortality chart showing that the mortality rate in Africa is very high. And I think primarily with those very high PSA rates, then majority of our patients present with metastatic disease. If you just look at the bar chart, you can see that mortality rate in South Africa, in Middle Africa, in Western Africa, East Africa, and Northern Africa very much exceeds what happens in North America and Northern Europe. So the benefit of systemic therapy will be felt a lot in our region. So if we look at where systemic therapy is used for prostate cancer, it starts very early for localized disease. And the benefit in localized disease is in preventing recurrence, whether that recurrence is a biochemical recurrence or metastatic disease. And when it is applied in biochemical recurrence, then the benefit is in reducing the rate of progression to metastasis. And when we use it in the metastatic setting, our goal is to reduce the time to death from prostate cancer. And these terms are probably very familiar to all of us, that we have a period where the tumors will be sensitive to hormonal manipulation, and we'll have a point where this doesn't work at all, and we have to apply other modalities of treatment. To summarize the types of systemic therapy that are available, we have androgen deprivation therapy, which has been around for decades, and mainly in the form of GnRH agonists and GnRH antagonists. And I just noted that there was a new FDA approval for an oral GnRH antagonist, which is the relugolix, which was approved in December 2020, which might be beneficial for us in Africa and in other regions. And then we have androgen synthesis inhibitors such as abiraterone, and we have the androgen receptor blockers, where we have the first generation like bicalutamide and second generation like enzalutamide and others, and then chemotherapeutic agents such as docetaxel and cabazitaxel. And we have new molecules in the last 5 years, such as PARP inhibitors for a specific number of type of patients with either a HRR mutation or a germline mutation in the BRCA. And then we have immunotherapy for the patients who have deficiency in MMR or microsatellite instability, or those patients who have a high tumor mutational burden. And then, of course, we have bone-directed therapies and more recently, lutetium-based therapies. So whereas we may have very few patients with localized disease, it's important for us to know where the systemic therapy is important. And I think the important considerations even for us is our life expectancy. So already life expectancy in Africa is limited because of other diseases such as infectious diseases, HIV, and other non-communicable diseases. The presence and absence of comorbidities is important when we are determining whether we should give systemic therapy for localized disease. And then the risk categorization of patients is also important. The NCCN guidelines has a very robust risk stratification, but generally there will be 3 groups where we have very low and low risk, intermediate risk, and very high risk patients based on the size of the tumor, the Gleason score, and the PSA. So what is the place for systemic therapy, even here in Africa? For very low and low risk patients, the treatment will mainly be active surveillance or watchful waiting. But in the patients who have a high life expectancy of more than 10 years and have had a discussion with their doctor, primary treatment will either involve surgery, and androgen deprivation therapy will only be considered after radical prostatectomy if a patient has a positive margin, seminal vesicle invasion, or a detectable PSA. I have to say in my practice, I haven't seen any patient with very low risk and low risk disease. Majority of our patients have a Gleason score of more than 8 and a PSA of more than 10. But we need to know this information for the very few patients who see with a very low risk or low risk disease. We have a couple of patients with intermediate risk, which have to be classified as to whether it's favorable or unfavorable. And we would treat patients with a life expectancy of more than 5 years. And the primary treatment here will be radiotherapy plus androgen deprivation therapy. And we would only consider adding ADT in after surgery in those with adverse features or those who are node positive. In the high-risk group and very high-risk group, the role of systemic therapy becomes very important. We have a subset of our patients in Africa who will have this localized disease, which is very high risk. And there will be benefit for radiotherapy, for ADT as primary treatment in combination with radiotherapy. And I think it's important to look at what is the role of additional therapies apart from ADT, such as docetaxel and abiraterone. There were no African sites included in this trial, but I just said I will show it. So new data that was presented in September this year at the ESMO Congress showed this data of addition of abiraterone to androgen deprivation therapy with patients with localized disease, which is high risk. And you can see that the time to metastasis was significantly improved with 2 years of androgen deprivation therapy. And this data has led to the inclusion of abiraterone in the guidelines. There was also a benefit in overall survival in this trial for addition of abiraterone acetates. If we look at docetaxel, the trials haven't been as promising. We have 3 trials that have shown improvement in relapse-free survival, and we have 3 trials showing no improvement in relapse-free survival. And so most of the guidelines recommend this in a very small select patients with high risk localized disease. If we look at imbalance, abiraterone is potentially far out of reach for most patients in Africa because of the cost. Docetaxel is more likely to be more readily available because it is cheaper, and we use it for other diseases and maybe the drug that will be available for patients with high risk localized disease. For patients with biochemical relapse, addition of androgen deprivation therapy is for patients who have persistent PSA rise without systemic disease. And if the doubling time despite ADT is less than 6 months, then we have evidence for other agents, apalutamide, darolutamide, and enzalutamide. I have to say that in our practice, these agents are not readily available. Even though I work in a private tertiary hospital, very few patients are able to access these drugs. And I think the data is very strong. If you look at this Spartan trial looking at apalutamide in combination with ADT as opposed to placebo, you can see that there was a significant time delay between relapse and development of metastasis. And the same for the enzalutamide trial, which was a PROSPER trial, additional 22 months between PSA relapse and development of metastasis. And finally, in the ARAMIS trial, where darolutamide actually showed a significant improvement. So this is where a majority of our patients will be, which will be the initial diagnosis as hormone-sensitive metastatic prostate cancer. For more than 40 years, ADT alone was the preferred therapy. But in the last 10 years, we have seen data showing that addition of abiraterone or apalutamide or docetaxel or enzalutamide has shown significant improvements in outcomes of patients. I think it has also brought up the issue of which agent should we choose for which patients, and there'll be variability based on the age of the patient, the volume of the disease, and the life expectancy and the presence or absence of comorbidities such as diabetes for abiraterone and docetaxel, where we have to use steroids in addition to the treatments. And just to summarize the data for docetaxel, 3 big trials showing improvement in median overall survival by up to a year when docetaxel was added to ADT in patients with hormone-sensitive prostate cancer. And docetaxel seems to do better in patients who have high volume disease, which is likely to be where most of our patients fall. And then we have similar data for abiraterone in the STAMPEDE and LATITUDE trial, which shows a significant improvement in the hazard rate for death. And the same for enzalutamide and the same for apalutamide. I will not spend too much time on this. And then, so the question is, how do we choose and what should we use first? And now there's also new evidence to say, can we combine the treatment for even better outcomes? And so this was the PEACE-1 trial that looked at combination of androgen depression therapy with abiraterone and docetaxel, showing a really big improvement in patients who receive first-line treatment with combination or triplet therapy. Whether this is something that is going to be available or accessible or affordable to our patients is another matter. But I think over the years, what we have learned is that, yes, we can use ADT alone and gives us an overall survival of up to 3 years. If you add docetaxel, you get an extra year. If you add abiraterone, you get an extra 1.5 years. And when you use a combination, you move the overall survival to up to 5 years, which is a significant improvement in outcomes for our patients. And we hope that our patients in Africa are going to benefit from these molecules. If you look at castration-resistant prostate cancer, which is eventually where all patients will end up, it is recommended that a biopsy of one of the lesions is done so that we can look for molecular signatures that will tell us whether the newer targeted therapies are going to be helpful. So if you have a deficiency in MMR or microsatellite instability or a high tumor mutational burden, then these patients benefit from immunotherapy. However, none of these tests are readily available in our setting. And for us, we have to set out specimens for these tests. And immunotherapy is really not reachable for a majority of patients because of the cost. If patients have a gene mutation in any of the HHR genes, then they are eligible for a PARP inhibitor, which is slowly gaining traction in our markets. If you look at all the treatments that are available, you use what you haven't used before. And there's some other treatments that are available, such as corticosteroids, ketoconazole, and DES. And if you just look at how much progress has been made over the years, in 2004, we only had docetaxel, and now we are moving on to treatments such as PARP inhibition and immunotherapy and combination therapies. So while we have a large burden of the disease in Africa, we still have a lot that we can do for our patients, whichever level of disease that they have. Thank you, and I'd be happy to take any questions with regards to this presentation.
Thank you, Dr. Sidna. I would like to remind everyone to participating in this session that you can type your question at the discussion box at the Q&A so that we can discuss later. Thank you, Dr. Sidna. I think the next presenter available here is Dr. Kosti Yamora. I don't know if Dr. Yamora sent his presentation, but we are happy to see him here.
Hello, everyone. This is Dr. Kosti Yamora. I just want to take this time to thank the organizers for this year's aortic conference for the opportunity to give you some updates on radiotherapy for prostate cancer. So I'm going to share the screen right now. We'll begin. So here are my disclosures. Today's objectives are going to be focused on talking a bit about the background, workup, and risk stratification, definitive radiotherapy. This is going to be a high-level overview, post-operative radiotherapy, and some genomics, and then end on a few comments on imaging in radiotherapy. So by way of introduction, here's some anatomy of the prostate. There's an MRI scan on your left side, and the green dots showing you the prostate outline, and the middle is the central zone. You can see this pointing to disease in the left peripheral zone, and the rectal wall is posterior. We also pay attention to the lymph nodal regions where the vessels are, and so we have the common iliacs, external and internal iliacs, as well as the obturator. As radiation treatments, we focus on those areas to deliver effective radiotherapy. So how we often treat is based on risk stratification. So it goes from NCCN very low risk all the way to very high risk. And based on the T stage, the Gleason and the PSA, and with the newer Gleason group grades, often going from 1 through 5, 1 being Gleason 6 and 5 being Gleason 5+5, which is 10. And based on that, with all the other features in here, we're able to offer radiotherapy with or without hormones, so on and so forth. And so with that, the level 1 evidence that really give us the gold standard for treatment of localized prostate cancer is really the PROTECT study published in the New England Journal of Medicine in 2016 that took men with mostly low and intermediate risk, but some high risk patients in there as well, to active monitoring, external beam radiotherapy with or without hormonal treatment, ADT, or surgery with radical prostatectomy. And in this specific study, active monitoring was PSA every 3 months for 1 year and then every 6 months, which is quite different from the active surveillance regimen per NCCN guidelines. So it's important to note that. And surgery was 82% was open, radical prostatectomy, 66% nerve sparing. There was no laparoscopic procedures or robotic procedures. And as mentioned earlier, 29% were actually ECE upstage T3, which makes them high risk. And the results was very impressive that for all comers, the freedom from disease progression was really, there was no difference between the red and the blue line, which is the surgery and the radiation group. However, in the active monitoring group, there was a trailing in terms of freedom from disease progression. And below here, you see how the patients continually underwent intervention as the years went by for the active monitoring group, meaning that they were transitioned out of active monitoring into some form of intervention, either with radiation or surgery. So with this knowledge, we'll go over some more modern schedules that are being adapted for radiotherapy. These are hypofractionated schedules that are done in shorter fractions as opposed to the 39 to sometimes 41 days of daily radiation. These are hypofractionated regimens that have a higher dose per fraction, per daily fraction. Several different studies across the world have studied this and have shown good disease control as well as tolerable side effects, and also has savings as well, say cost savings efficacy as well. And in the United States, this is mainly sometimes for convenience and also for insurance companies to save money, but for areas of limited resources, this could actually be significant savings as well as throughput for patients that need to travel from far and wide to come and get treatment. If they can finish it within a week or two versus having to come and stay in a place for 5 to 9 weeks in some instances to get radiation done. And I have to say that the NCCN has followed suit and given multiple fractionations for this. Also, there's an ultra hypofractionation, which is also called stereotactic body radiotherapy, SBRT, that is even higher doses per fraction. And these are all recommended across the board for all risk groups, including even low volume M1 disease. So what needs to be considered when prescribing these hypofractionated and ultra hypofractionated regimen is oftentimes urinary symptoms through the AUA score and prostate size. So in our practice, we often would do different versions of hypofractionation if the gland size is too big or versus when it's less than 50. And in fact, if it's greater than 80 or 90 cc's, we'll go conventional and do the 1.8 gray or 2 gray per fraction. Obviously, with the AUA scores greater than 15, we exercise caution because there's data to suggest that patients will actually get more side effects. So here again, we see the NCCN risk stratification across and as well as the dose fractionation. And there are all these different fractionations that are allowable. Also, brachytherapy, which I'll talk about briefly. Seed implantation is an option for localized radiotherapy for prostate. Combinations with external beam is also below here. And ADT use. Short-time ADT 4 to 6 months for unfavorable intermediate risk, and more of the high risk and low positive, they go long-term ADT. So briefly on that, androgen deprivation therapy, ADT, can be achieved in multiple different ways. We can have the surgical castration, which is bilateral lacherectomy, which is still used today, and also the GnRH agonist and antagonist are being used more routinely in the US. The non-steroidal anti-androgens as well, bicalutamide and the second generation as lutamide and flutamides, and also the 5-alpha reductase inhibitors and more agents are coming out every month or so. So stay tuned as this list continues to grow, that this forms a foundation of prostate cancer treatments once you pass unfavorable intermediate risk all the way through metastasis. Briefly on prostate brachytherapy, this is where seed implants are placed within the prostate, either permanent or transient, which is the low dose rate is permanent, and then the high dose rate is transient using different isotopes. And this is a transperineal approach. You can see the needle goes through a template here and is able to go through the perineum into the prostate and deposit radiation, high dose radiation in the prostate, being viewed through a transrectal ultrasound probe that is able to visualize the prostate through the rectum. On the left side, you see an ultrasound view, the transverse versus a sagittal view with the urethra outlined in both instances here. And below is usually when we do the high dose rate, we often use a CT-based approach, and we have the draw positions and how we're able to spare the urethra with the contrast being shown here. As you transition more to the very, very high risk, almost metastatic patients, you start to introduce chemotherapy. And docetaxel has been shown to be effective for the very high risk patients only in combination with external beam and ADT. And this is based on some clinical trial that was conducted showing benefit with docetaxel for the very, very high risk patients. I would say that in metastatic era, docetaxel is actually used for higher volume disease, not for low volume metastatic disease. So the distinction needs to be clarified. And more recently, the STAMPEDE trial has really given us a window into how radiotherapy actually has improved failure-free survival and hence has been encouraged with patients with oligometastatic disease. And so we are seeing more and more patients with oligometastatic disease being treated with radiotherapy as well as systemic treatments. And so the NCCN guidelines is recommending that because of significant improvement with the addition of radiotherapy to primary in the failure-free survival, not overall survival, and they're also recommending this hypofractionated and SBRT dose regimens are useful in that context as well. So what is oligometastatic prostate cancer? So the definition is very varied, and for most articles will define it as somewhere less than or equal to 3 or less than or equal to 5. So if you have any of these metastatic sites, that's considered oligometastatic. Anything beyond 5 is often not really going to qualify for that. And this is how we would determine which patients will benefit from localized radiotherapy or not. Briefly on protons versus IMRT, so protons versus photons. And now protons is superior from a physics standpoint and in terms of not having any low dose spread right where the edges. Very effective for spinal cord, brainstem, pediatric patients, and you know, we can compare up here and below here. There's a low dose spread, but not so much for an adult pelvis. So the data is showing that with the conventional radiotherapy, with the modern techniques, where there's a lot more image guidance with fiducial placements and very targeted immobilization, that there is really no difference in early toxicities for protons versus photons, and so NCCN is saying it offers no clear benefit. IMRT versus photons. However, there are ongoing studies from MGH and University of Pennsylvania randomizing patients to protons versus IMRT for lower and intermediate risk prostate cancer, so we can learn more. And again, to emphasize that there's no real oncologic benefit, mostly being viewed for toxicity benefit. So after surgery, how do we integrate radiotherapy? The field is rapidly changing and is really moving towards rising PSA or persistently elevated PSA, which is termed early salvage or salvage, rather than adjuvant, which is where you just look at a path report and give radiation. So here, if there is no evidence of metastasis, that's where we consider an early salvage approach, where we give radiation to the area where the prostate was sitting, known as a post-operative bed. And then if there is metastasis, then we consider systemic treatment. This field is also changing more with the use of genomics. And one of the most favorite ones is Decipher Genomics, which is a 22 gene classifier that is able to predict the risk of metastasis within 5 years. And so you can imagine that if you finish your surgery, your surgical specimen can be sent for this test. And if you do have high Decipher testing, there is indication, there's data to suggest that those patients who benefit from adjuvant radiotherapy, or at least early salvage radiotherapy, rather than waiting for salvage, because by that point the benefit is less. However, If they have low decipher, you can actually observe them until there's a PSA rise or there's a BCR, and then you can give salvage. Now, if for some reason they don't get the decipher testing until the PSA rises, that's also fine. You can actually use the decipher test to really help you intensify treatments for those patients that you know will not benefit fully from just a regular salvage radiotherapy. And if they had low decipher, you can just give the regular salvage. So the field is progressing to personalized treatments, and I think that's what is really going to be the way of the future. Briefly on imaging, so most often than not, and I showed you earlier, we have a multi-parametric MRI of the prostate that shows us, whether there's extra prostatic extension, some nervous invasion, some invasion in the rectal wall. The extent of the disease can really be evaluated with an MRI. And then for a bone scan, it will often be used to see if there's any metastatic disease at diagnosis. Now, there's low sensitivity of the bone scan, especially at low PSA. So after the bone scan, if things are not clear, oftentimes they would do an FDG PET, which is now routinely used for prostate cancer. You can use a sodium fluoride or choline PET. These are falling out of favor because of poor sensitivity and high false positivity at low PSAs. So the Axamine PET was really approved in 2016 by the FDA. It's been used quite a bit, which is much more sensitive than a lot of these I've described up here. But what's really taking over more recently with FDA approval in 2020 is really the PSMA PET, which is also not only for recurrence after treatment, but also therapeutically, there's agents coming that can actually be targeted to the PSMA antigen and actually help really to treat patients as well. So this is a whole new lecture on its own, but I just wanted to touch briefly on it. But for imaging, for treatment, this is how PSMA PET is changing or will soon change the landscape of prostate management, because you can see here they had 233 patients with 799 lymph node mets. And what we often focus is on the true pelvis. And you can see this is how our pelvic lymph node radiation fields, this is all they cover. And there's a whole lot of recurrences that were picked up in the PSMA PET that was not going to be treated with our regular fields. And this is probably a source of a lot of recurrence as well. Whether the ADT we give long-term helps take care of this is probably a hypothesis, but obviously this means that there's going to be a lot of state migration with this routine use, and understanding how to really use this imaging in this era and how to compare results to results in the past is going to be critical as we adapt to new imaging modalities. So with this, I want to really thank the organizers again, and also all my collaborators, both on the US side and Ghana and other parts of the world, for continuing to really push the field forward. And thank you for your attention, and I'll be around to answer any questions that will come up.
Thank you, Dr. Yamoha, for your very comprehensive presentation. So I'll hand you back to the facilitators to continue.
As we all see, we have some present who haven't been able to join. So what I would propose, there was a presentation that was initially removed because of the time limit. I would propose to do this presentation myself before because we have some room, before we move on to the question. We have started having some questions. So with your permission, I'm going to do that. Just a second. Okay. So the objective of this presentation is to bring here the recent development that we've had on the clinical characteristic of prostate cancer in sub-Saharan Africa. And these data are from the MANCAP consortium. So clinical characteristics of prostate cancer patient in West and South Africa in the men of African descent and carcinoma of the prostate consortium. I have no disclosure here. African men have one of the highest burden of aggressive and lethal prostate cancer, as mentioned by the previous presenter. And there have been some case studies that report advanced disease in sub-Saharan Africa with higher prevalence of C34, higher Gleason score, and higher PSA value. However, there have been no large-scale studies in sub-Saharan Africa to characterize the clinical features of the prostate cancer in that region. And reported data are often underestimating the true burden of the disease. And these are the data we had back in 2003, where we compared Senegalese, African American, and US-wide, where we saw that mean PSA is the highest in Senegalese men, a higher proportion of T3, T4 disease, with a high proportion of distant metastases, even if the biggest proportion was not assessed for metastases. And these data are from Dr. Rebek, who just presented, summarizing the data that are existing in Dakar, in Accra, Cape Town, and different parts of South Africa, where we see that the mean PSA is generally high at the time of diagnosis. The mean age is very high, 68, 67 and above. Mean PSA, as he mentioned, very high. A good proportion of advanced, a high Gleason score, and a high proportion also of T3, T4. So this is what we see, and probably reflects the situation where we do not screen. And then if we look at the different regions, we see a good proportion of prostate cancer in the Caribbean areas, in Southern Africa, and these are the data from GloboCan. So prostate cancer is really very important. And the aim of our proposed study was to characterize the clinical features of men with prostate cancer in sub-Saharan Africa, and to compare demographic and clinical features between the West Africa and South Africa. And also to use risk prediction model of demographic, lifestyle, and comorbidity condition to examine association with high PSA, intermediate and low risk based on D'Amigo classification. Between 2016 and 2020, we recruited 2,588 histologically confirmed prostate cancer patients into a multi-center hospital-based study via the MATCAP consortium. Cases were collected in West African countries, Senegal, and 2 centers in Ghana, 2 centers in Nigeria, and also in South Africa, where we had 2 centers. Participants all completed a detailed epidemiological questionnaire, including demographic, lifestyle, family history of prostate cancer, symptoms, assessed by the IPSS symptom score. And we also had data on comorbidities that were extracted from medical record. Clinical data were collected from medical record abstraction, and PSA referred to PSA at diagnosis. All centers use a similar protocol, and the study was approved by each country's IRB. We use descriptive statistic and t-tests and mucosal rank tests and chi-square tests were used to compare patient characteristics. Multivariate logistic regression was used to measure odds of high risk prostate cancer versus intermediate or low risk. And alpha was 0.5, 0.5. It was set there for significant. The result, a total of 2,588 men with prostate cancer was included in these studies, and roughly half of them were from West Africa and half from South Africa. Prostate cancer patient in West Africa was significantly older compared to South African. The majority of patients had a high D'Amico risk category. Median PSA at diagnosis was higher in West African cases compared to South African cases. So 93 compared to 28. In West Africa, we had a high prevalence of moderate to severe symptom compared to South Africa. Clinically invasive diseases were more prevalent in West Africa compared to South Africa, referred to T3 or plus. However, the distribution of aggressive lesion group was similar in the 2 geographic areas. Majority of patients were treated with hormone therapy in both West Africa. However, in South Africa, a large proportion of patients was are treated with radiation therapy. So this table summarizes the differences that we have in terms of age at the diagnosis. We also have some differences in BMI, the symptom score, etc. For the PSA, as we mentioned, it was significantly higher in West Africa, and even if the pool data indicate that the PSA is very high. So when we look at the order of having intermediate or low risk versus high risk, we found that age was associated at univariate analysis, as well as BMI, smoking, severe IPSS, first degree relative with prostate cancer. But at univariate analysis and multivariate analysis, only age was significantly associated. And for South African, the association were found above 60 years, while in West Africa, it is more starting from 70 years, going beyond. So in conclusion, men in Africa present very high risk prostate cancer. Patients in West Africa had characteristic of more advanced disease at presentation than their South African counterpart, indicated by high PSA, prevalence of adverse clinical features, and a greater proportion of prostatic cancer. This data further emphasizes the need for development of prostate cancer screening guideline within South Africa. Thank you. So I think it is useful to bring back these clinical characteristics because in this session we mentioned issues of epidemiology, where we mentioned the concept of screening. We also mentioned systematic therapy, that is, if we see the state of the disease that we have that is relevant, and also radiation therapy is emerging in Africa. So while we are still waiting for question, there is a question that come to us from Luca Incroci, mentioning the ethical issue of doing screening if we are not able to do the treatment. So the question clearly say, should we screen if we don't have the possibility of training? I think we'll have a comment from Dr. Rebeck first, and then I think each of us can have an idea on that.
Thank you. Yes, it's a very important question. And I think that the answer is, of course, we should not do screening if we don't have the ability to manage and treat the cancers that are identified. And the question becomes then, what level of treatment, what kinds of treatments do we need to be able to offer? For example, if we're identifying very early cancers for which treatments might be available, that's certainly something that we should be considering if we can convince ourselves that lives will be saved. But of course, many of the treatments that you heard about from some of the other presentations are not available. And particularly for advanced disease, some of the newer chemotherapy regimens and the radiation treatment regimens that you just heard about. So I think that it's really a critical question that we need to think about screening. Can we do it at all? Do we have enough evidence to screen? Do we have enough evidence that it will save lives, given that we can't do a trial? And can we treat the people that we do find to have a positive PSA? And if the answer is inadequate on all of those levels, we may just have to decide that we shouldn't be screening, maybe ever, and take the consequences of advanced disease as a continuing problem in Africa as the way that it has to be. So it's a very good question, and I'd love to hear the opinions from others.
Thank you. And I think before I move to Dr. Sitna, the other thing to consider is the cost. Like, what is more cost effective? Is it treating a patient that is diagnosed early? And so one part of the question rely on the fact that now most treatment for localized disease are available. Surgeons are able to do surgery. Radiation therapy machine are, coming maybe slow, very slowly, but they're coming. So it means maybe it can be doable on the short term. Then the question is, what is more affordable? Treating the patient at the localized disease, or having to pay very expensive drugs for the long run? And I think you can have a comment, and then we have a Sidna develop on that.
Can I give a comment about that? This is Kaushe here. Sorry, I couldn't be fully on, so I'm on my phone here. So one of the things that we're also struggling with is the issue of not so much as the screening, but what do you do about it? And I think both Tim and then Mohammed, you both touched upon it, is that if we are going to be screening all these patients, and then what are we going to do about it? And I think the problem is really the action points that you take up to that. And if we can identify, not only just screen, which is fairly a low cost approach, but actually have a further filter that will let us know which patients actually are harboring aggressive disease. And there's research going on in the polygenic hazard score, which is a little bit different from the polygenic risk score. The polygenic hazard score that is really looking at the risk of developing aggressive disease. There are other more expensive modalities, but may not be a good solution, which includes MRIs and things like that. But the MRI industry, the imaging industry, is developing these biparametric MRIs that potentially could be low cost and high throughputs that may help us identify patients that have the higher upfront aggressive or high-grade lesions, because those are those that will need to be treated. And currently, I think the guidelines, we are still struggling with it because they are not addressing younger men of African origin getting the disease, and we are seeing a lot of them coming in late stage. In my own practice, I can feel that there is a clear influx of higher metastatic, oligometastatic patients coming into clinic the last 7 years, just based on even some of the guidelines that have been changed. So there is value to screening. The struggle is, how do we not only just screen, but there should be a second level of screening that will say, yes, we've identified abnormality, but it doesn't mean we should act upon it, but we have to do something else to fine tune that. And I think that's where the field is going, rather than abandoning screening altogether, because it will affect a lot of men.
Thank you. I agree with this point. And Dr. Sidna, if we do not screen, we'll be having patients that are diagnosed at a very advanced stage. What is your perspective on that? Because then the medical oncologists are the one handling the patient on the long run.
Yeah, thank you. I think that while we may not be screening them, we should at least make people aware that there is a problem of prostate cancer, and if they have symptoms, they come early. Because in clinic, we are sitting with patients who can code compression, which is, definitely morbidity and can cause mortality for patients. It's very expensive to treat. We have a lot of patients with high volume disease that will not only will benefit from ADT, but definitely need many add-on therapies. So while we have seen trials that show screening has not increased the number of lives saved, at least if we get the patients at an earlier stage, then we will need less treatments for them, especially if these treatments are very expensive. If you look at a lot of the abiraterone trials, in the high-risk localized disease, you need to give abiraterone plus ADT for 2 years. So this treatment is really not something that many of our patients are going to be able to afford. So if we found them earlier where they had lower risk or maybe intermediate risk, then the treatment cost will be much cheaper. So in as much as we're talking about screening not showing benefit in trials, but it may just for us help us to see patients earlier and needing less treatments and needing lower durations of treatment.
Thank you. Dr. Rebek, let's come back to the natural history of the disease. I anticipate that it's hard to know the natural history if we don't diagnose the cases very early. for us to know how it evolved. Maybe a good compromise would be like Dr. Kosji just said, to develop polygenic hazard score, so that we can at least know who need to be treated more aggressively and who can be followed up. So how do you see this thing evolve in the near future with the development of genotyping and all this polygenic score that can be that we can have? What do you anticipate can be the right balance between screening and having the natural history and developing these scores?
It's really a challenge because the data, the evidence base that we have right now is quite limited. We certainly have an evidence base that suggests knowing polygenic scores and hazard scores will be of value to a lot of different purposes, including, as you say, identifying those who are likely to have the most aggressive disease and therefore go on to need more aggressive treatment. So it certainly is something that should be considered. It's being considered in other parts of the world, and it has potential for value, but the evidence base in Africa isn't clear. There's a suggestion, of course, that in the African setting, cancers tend to be more aggressive. So, but we don't know, we can't tease apart yet whether that's due to an innate aggressive nature of the tumors and the susceptibility to develop aggressive disease, or just the fact that they're diagnosed at a later stage. So those are things that need to be teased apart. But the ability to use risk stratification at a variety of levels is something that we absolutely have to consider, because not every man should be screened. We know that already, but in particularly when we have to think about the cost and the cost benefits, we only want to find those cases or screen those men who have the most likely chance of aggressive disease and lethal disease. So I would say that if we're able to identify models that include polygenic risk or polygenic hazard scores, and as well family history, age-based models, and possibly something related to obesity, which is known to be conferring aggressive disease. These are models that need to be developed. If they can be developed, then we would have to learn how to apply them and develop risk stratified approaches. And I think that's a really good way for us to move forward. It just requires a lot of research in order to get there to make it clinically useful.
Thank you. And thank you also for answering another question I wanted to ask regarding the clinical presentation, whether it was due to the lack of screening or the innate biology. And I think with we'll have some answers soon with all the studies that are underway currently. So, and I think that is very important, because even if in other countries, and of course you just mentioned the modification of the screening in the US has led to like a so-called more advanced disease and diagnosis, even if it is not very, very consistent. And that's the case in all those countries who did not use to do screening, like in Denmark in the past. Yeah. Okay, thank you. I have a question for Sitna, and like just trying to we are surgeon, and I'm sure there are, of course he is a radiation oncologist. Sometimes when we look at the data about systemic therapy, and we look at how the trials will highlight some survival of a few months or something like that, and we always ask ourselves, why do we spend that much resources just for the benefit of a few months? And I would like to have your perspective, because for us, like it looks like it's very expensive, very costly, and it's on the long run, and the benefit is a few months, sometimes a year.
Yeah, I think that's a good question. We also get that question a lot from our pediatric colleagues who have better, survival curves. But I think when we're looking at the curves, we're looking at the median outcomes. We're looking at either the median overall survival, or the median relapse-free survival, or the median metastatic-free survival. So I think prostate cancer is kind of like one of these cancers where we have seen huge impact. So for us, 1 year is such a big deal in the sense that there are patients who in that trial will have no disease or will have no progression for many, many, many years. Even if not all the people in the trial will benefit, you have like a significant subset of patients will have a significant improvement in outcomes. And so for us, the question is, how do we predict those patients who are going to have a better outcomes? And that's why we need to develop, biomarkers to predict in the trial which are the patients or who are the patients that actually showed the most benefit and who are the drivers for the outcomes in the trials. So in as much as you may look at an immunotherapy trial where the outcome is better by 4 months, in that trial, there are patients who had durable responses that lasted even up to 2 years. And for those patients, there was a significant improvement. Yes, the treatments are costly and the length of treatments are long, but for individual patients, this is important for them in terms of their quality of life and in terms of their length of life.
Okay, thank you. And I think that will lead us also to the issue of finding polygenic hazard score to identify those patients who are chemosensitive, those who are radiation sensitive, etc. And I think this could be the way to move forward as well as the drugs are being developed. Thank you. I have a question for Dr. Koski, and that has something to do with the Timor board that we are organizing currently in Dakar. Before we have the radiation machine about 2 years ago in Dakar, we used to operate all the patients if they were localized, irrespective of the risk, the level of risk. Now we have the medical oncologist on board, which we did not have. We have the radiation oncologist, and we end up sometimes not doing surgery, but doing radiation therapy, or after surgery doing radiation therapy or hormonal therapy. So I don't know in your practice how you feel it. Sometimes some surgeon would say, okay, since radiation therapist has came, we are doing less surgery. We were not doing that many before because most patients are at advanced stages. So how do you see that happening in your center? What is the place of the patient opinion, or do we just practice the guidelines?
Looks like he may have fallen off the call, so I'm not sure.
Yeah, I think Sitna can answer to that question because there is one component. Yeah.
Yes. I think you're bringing up an important point of having a tumor board. And at least for us here at the hospital, we have developed a specific tumor board for genitourinary malignancies, especially the prostate. And it is important to make that decision before either the surgeon or the radiation oncologist touches the patient. So sometimes patients go for surgery that did not need to go for surgery, and some patients may have benefited for surgery but went on to have radiotherapy. So having that initial discussion, once you have your imaging and you have your PSA and your Gleason score, deciding what would be the best. And then obviously the patient is very important. Both these treatments have issues with erectile dysfunction, with incontinence, and if you have a center where the surgery is low volume, then you're more likely to have more side effects if the proper surgery is not done. And if you have centers for radiotherapy where they're not doing IMRT, then you're more likely to have more side effects. So having that initial decision before anything is done for the patient is very important. And obviously some patients don't want to have surgery or it's not available to them. I think one of the biggest challenges for us in many parts of Africa is that radiotherapy is not readily available. People have to move to different centers for it. Here in Kenya, I would say that we have quite a bit of locally advanced disease, so majority of patients don't go for surgery, but they do go for radiotherapy. But having that discussion with the urologist beforehand is very important. I'm sorry, I don't have any radiotherapy background to answer any more technical.
Thank you. Thank you. That will bring us again to the cost of drugs. I don't know what it looks like in Kenya in terms of access to the second line radiation therapy. I mean, beyond the orchiectomy or agonist or antagonist of LHRH. So that is important. The reason why I ask, it's because in Senegal, recently the government has subsidized most of the chemotherapeutic agents for cancers, but not this hormonal treatment for prostate cancer.
I think it's the same in Kenya. We have the National Health Insurance Fund, that's the public insurer. And of course, chemotherapy is more readily available. And if you look at the trials, the chemotherapy is given for a limited number of cycles. So anything between 4 and 6 months of treatment. Yet the newer molecules, patients are taking them indefinitely as long as their cancers are responding to the treatment and they're tolerating them well. So that may be years of treatments. And because they're newer treatments, they're more expensive. Just to give you an example, standard docetaxel chemotherapy might be about 300 to 500 US dollars per cycle. But for abiraterone or enzalutamide, you're getting to 1,500 US dollars per month of treatment, which is definitely out of reach for most patients and may not be supported fully by the national health insurance or other insurance companies. So that might mean that many of our patients may get chemotherapy as opposed to the newer molecules. If you come to immunotherapy, this is about the $3,000 every 2 to 3 weeks, which is definitely even for middle income or high income earners out of reach.
Yeah. I think the solution will come from high above. I have the privilege to participate on the Lancet Committee on prostate cancer, Commission on prostate cancer, like to try to plan the coming years on what will be needed and how to make it available. I think if we have the possibility to talk to policymakers that can start from WHO, that would be helpful because definitely it's not affordable. Just take the example of agonist or antagonist of LH-RH. Most patients would not like to have orchiectomy for the preservation of the body image. They opt for the injection, but realize that after a few months, either they cannot observe the treatment or they cannot afford it. So there is a big challenge there. If we agree that the clinical features are more relevant to that long, prolonged treatment as opposed to localized stage where something else can be proposed. Yeah. But we're happy to have medical oncologists. If the disease is advanced, we just call you and you are the best surgeon, the best doctors, and I know you can do something for the patient.
Yeah. Just to add, when you're talking about access to drugs, is the development of generics or biosimilars, because I think in other diseases such as HIV and even other non-communicable diseases, when you have effective generics or biosimilars, they significantly reduce costs. And this is something that even as we are talking to policymakers, we would be looking at this as a potential way of increasing access to treatments.
Okay. Dr. Rebek, I know you've traveled a lot in Africa. Do you have any comment on that issue, access to treatment?
Well, I think the points that were made are very relevant. The ability to identify the treatments that are effective and accessible is the challenge, and the accessibility is, not only due to cost but also the supply chains in some places. And so I totally agree with the idea of biosimilars being able to develop manufacturing within Africa or in places that allow easier access to some of these treatments. And it's really a question of capacity and cost that limits it. And I'm not sure how we address that, but there are groups who are trying to. As you know, the BioVentures for Global Health and some other groups are trying to develop some of these approaches to better understand what is available and what kinds of things need to be done to make drugs more widely available. And the IAEA is working toward understanding better radiation therapy access. So there are groups trying to address some of these problems, but ultimately it comes down to cost and the ability of ministries of health and other payers to be able to provide the capacity that's necessary to treat cancers. And so I don't have anything more to add.
Okay. Thank you. I think we've had a very important discussion, and we talked about the development in terms of epidemiology. Screening was very important here, and the debate is whether to screen or not. If we are to screen, what to do. And as Dr. Ebek mentioned, we are working on a systematic review that will at least give us a sense of what is being done, and will help us fuel ideas on how to go beyond where we are doing now. Knowing that if we do not do any sort of early detection or screening, we'll keep having patient at a very advanced stage. But advanced stage can be different from one patient to another, which means that it could be because of the biology of the tumor or because of the long the evolution, and this will have something to do with the age as well. So it is important that the research is continued in order to find markers that can be polygenic hazard score that will identify those patients who will need to be aggressively treated where the limited resources can be focused. And it is also important to develop the multidisciplinary approach, because that will help, guide the patient at the right option, knowing that the medical oncologists play a key role, and that is very important because it's no longer a acute disease, it's a chronic disease like diabetes or any other disease. The patient will be followed up for a very, very long time. So policy makers should focus on prostate cancer in order to accompany all these initiatives, whether for diagnosis, management, and availability of treatment. It is important to say that there is a big burden, but it is more important to see what to do to be able to help in this disease. So I think the discussion was very important. We unfortunately will not be able to cover all the time that was allotted because many speakers were not able to join. And I don't know if you have any last words. As for me, that's what we had today. So if there is no other thing, I would like to thank all the presenters. I would like to thank all the delegates who attended this session. And I think we have a lot to do, and we'll be working on that in the near future.
Thank you, Dr. Jalo and your team. That was great presentations you made and interrogating a very important topic in Africa. From the epidemiology point of view, there are unique observations made as far as prostate cancer is concerned in men in Africa. And on my side, the message to take home, one of the messages that I have to take home is, in Africa, we have more specific questions than general that we need to interrogate to address the prostate cancer in Africa. With that short message, thank you very much for your presentations. That was a great session. And from this session, we will move over to a short record, which is a tribute to the founders of Aortic, the late Dr. James Holland, Professor, I beg your pardon, and Dr. Jimmy Holland, who was a psycho-oncologist. I would invite you to please listen to that short tribute. Thank you.